Welcome all to our SHIFTB World TB Day seminar. I'm really excited to have you all join us here today. We are hosting this together with the Athena Institute at the Free University in Amsterdam that I've recently joined. And this institute really has a lot of decades of experiences with transdisciplinary research, where research that is collaborative that integrates different scientific disciplines, but also experiential knowledge and societal actors to solve complex societal problems. And I thought this is quite fitting to use that theme for today's SHIFTB webinar. So we have a great lineup of speakers, and they will all talk about the different types of transdisciplinary collaborations that they engage in their research, and we can sort of have discussions after each talk for a few minutes about if there's any questions or things that you'd like to know, and then hopefully at the end we'll have a little bit more time left over. So I've asked all of the speakers to speak for about roughly 7 minutes, and our first speaker is Ashna Ashesh. She will talk about the role of impacted communities' experiential knowledge in a transdisciplinary approach to TB. Ashna is a lawyer, a public health professional, and an MDR TB survivor, and she sits on several boards of both global but also national committees in India. Among these are, for instance, the WHO Civil Society Task Force on TB, and the Governance and Management Committee for the National Technical Support Unit at the Central TB Division in India. And Ashna is also associated with the Survivors Against TB community. And her work focuses on community engagement, access to high quality care, including new diagnostics and treatment, a rights-based approach to care, TB mental health, and gender-responsive TB care. Ashna, we're really happy you're with us today. The floor is all yours.
Thank you so much, Nora, for that very warm introduction and for having me today. So I'm going to jump straight to what I'm going to be talking about. Broadly, when looking at the role of impacted communities and experiential knowledge in a transdisciplinary approach, I want to first look at who is the impacted community that I'm talking about here and what do I mean by experiential knowledge. Then I want to move on to why lived experience inputs matter in TB policy and care, and also pushing the envelope a little bit in terms of survivor engagement to understand how, beyond the lived experience of having survived TB, how we can benefit from the professional experience of TB survivors, and also provide examples through my work where experiential knowledge has shaped policy and care. So to begin with, when I'm speaking about impacted communities here in this context, in the interest of time, I'm confining this to TB survivors. The experiential knowledge I'm looking at here is one having survived TB, navigated the public healthcare system for accessing TB diagnostics and care, whether public or private, right? Now, why this matters? So this basically survivor engagement would fall within the broader subset of meaningful community engagement. And why it matters to engage TB survivors in TB policy and care from two perspectives. One is, of course, a rights-based perspective, which is that when there are decisions being made that concern our bodily autonomy and well-being, they cannot happen without us, right? We need to be not just have a seat at the table, we need to be setting those tables with the program, with civil society members, with other relevant stakeholders. That's one. Two, pragmatically, from an end user perspective, when you're looking at designing any intervention, it makes sense to get feedback and inputs from the people on the ground and understand what their needs and challenges are, so that what you design actually, we would talk about translational research, so that needs to kind of go from theory to practice, and bridging that divide, survivor inputs there are particularly relevant in helping you understand what the ground realities are, what the challenges are, and what the actual needs are, which helps you implement the policy and care interventions better, helps us scale them better, right, and helps us iterate if we need to. Now, when we look at dominant models of community engagement, typically survivors and the community at large are often at the periphery. And I don't mean to generalize here. There's, of course, significant progress that we've made in terms of community engagement in TB. But by and large, unless it's a kind of individual or particular organization's preference, it tends to be tokenistic or post facto. For instance, when we're looking at diagnostics, we often bring in communities after we've developed the intervention and we're piloting it, instead of bringing them in when we're designing this and sort of having more broad-based feedback there, right? Of course, there are groups that are working to change this. There are groups that currently already change this. SHIFTB is incredible with community engagement. The WHO is incredible. Fast TB Relay is trying to bring communities more upstream. But a lot remains to be done, because right now it's still downstream and it still happens from the perspective of service delivery. So we see communities are engaged in delivering TB care. So whether that's active case finding or ensuring that people, have peer counseling support. We do engage survivors and community members there, but that again tends to be a service delivery engagement, and the decision-making kind of aspect, or the enabling environment for engaging survivors that the WHO guidance talks about, that still remains wanting in most places. The other thing that we tend to limit ourselves on when we look at TB survivors, or we have them on board, is very often we tend to see them just as survivors, and what we miss out on there, I'm so sorry, that's my dog. What we miss out on there is basically, there are survivors who are lawyers, who are communication experts, mental health professionals, public health professionals, or personnel. And there's so much we can, when we talk about multi-sectoral engagement and the transdisciplinary approach to TB, there's so much we can pull on from there, right? Not just in terms of having survived TB, but also in terms of their professional expertise. For instance, somebody who's looking at comms and is a TB survivor may look at most of the messaging around TB and tell you that it's very pulmonary TB focused, right? The lungs are the symbol everywhere. Now, the burden of pulmonary TB is higher, that is true, but we know that that can happen outside of lungs as well. And so visual representation of EPTB remains limited or non-existent, even in global messaging, national messaging, or regional messaging. Things like this are something that people generally who have once survived it, who would notice it, who have the professional know-how, would bring to your attention. This is not to say people don't notice it, or that only survivors would catch on to this, but having been through and having lived through that what the impact of that exclusion can be, they are definitely more attuned to why there needs to be inclusion and where there needs to be inclusion, right? Now, in terms of in the real world where this kind of engagement helps, I'm going to talk you through a couple of examples. One is when in public-private partnerships, when TB screening interventions are designed, typically, and there are exceptions, but typically they tend to say TB screening, but they focus on pulmonary TB, right? Now, there have been instances where when you have EPTB survivors on board, they will flag that if you're screening for TB, it should ideally cover both TB and EPTB, PTB and EPTB. And the resistance that we typically got in that space was that it's too difficult to screen for EPTB, right? And one of the things that a survivor could flag there was that in this particular country's context, where the primary burden is lymph node TB, and physical auscultation or something like an FNAC, a fine needle aspiration cytology, would work, primary healthcare centers are actually capable of doing that. The second resistance that was brought on board was that this would be very resource intensive, screening for both, and these are hard to reach areas. And there again, because a survivor had the lived experience and the public health and policy knowledge, could flag that within that country's context, 40% of EPTB cases actually turn into PTB. And if this is a hard to reach area, then from a resource perspective, it makes sense to screen for both to the extent possible and then come back instead of having to go back again. So this is one example. The other clear example is the gender responsive framework of India. So initially, this was shared as a live doc, obviously, and there were changes to be made. But the initial draft of the framework was not entirely representative. It was well-intentioned, but there were not enough members from the LGBTQI community. There was one trans person, but it required significant revisions. There were mistaken assumptions. There was language that perpetuated stereotypes. And again, this is Survivors Against TB had taken this up, and it was like a 4 to 5 year process of advocacy, working with the NTP. And we were very fortunate that the NTP in this case was also very responsive. And it was truly an example of how multi-sectoral collaboration can work when you bring in survivors and you have the program and you have other partners as well working alongside. And we now have a revised framework that actually references things like chosen family in contact tracing, which is something to be very proud of, because most health documents, at least in my country's context, do not mention that, right? And this is yet another example of how survivor engagement and inputs and experience shaped policy and care very concretely. So I'm going to stop here and hand over to Nora. Thank you so much. And I'm so sorry about my dog barking in the background.
Thank you so much, Ashna. This was wonderful. I suggest that I'll take 2 or 3 questions and that you can answer them collectively. And if there's more questions, that we'll move that to the chat and save them up for discussion afterwards. So are there any questions or comments to Ashna? Who wants to make a start?
Right, I'm happy to ask one.
Okay, go ahead.
Hi, Ashna. I would like to hear more about, I think, the enabling environment and how to overcome maybe some of the power dynamics that might be at play. What are your thoughts and experiences on how we could address that and sort of make engagement with TB survivors more common and think about those dynamics?
Thank you so much. It's I mean, you're asking that question, but I'm actually going to use TB Proof as an example. So in one of the spaces, which is particularly empowering, you have peer researchers, right? I think very few places actually do that, where in terms of like Relay is trying to bring in survivors and community upstream, but TB Proof actually engages survivors and community as peer researchers. That's one way to sort of, when you start looking at survivors as co-producers of care and partners instead of just stakeholder, I think that flip needs to happen conceptually there. Also legally and in terms of policy there, because legally there needs to be an enabling environment. There actually has to be a budget for engaging survivors, because a lot of the times people want to, but there might be resource constraints. The other thing is we need to move beyond the token, we have one survivor or one community member, so that's enough. And this is something we pushed for with the gender responsive framework, where we said just one community member from the LGBTQI community isn't enough. We're going to try to get bisexual folks, trans folks, intersex folks. So we're going to put a call as wide out as possible, so that even with survivors or people from the LGBTQI++ community, you have a diverse set. So when you bring in, and I get that with committees, you can't have 20 people in, but within that committee, let's say you have 20 people, if even 3 or 4 are survivors, you will get that sort of diverse input there. Bringing them into committees where policy is designed, right? And like with this framework, it was a clear example where we got to co-write it. But that's because the person at the NTP, that team was very responsive. So that's still very person-based. It's not institutionalized. So institutionalizing these kind of best practices like TB Proof, the NTP with the gender responsive framework, all of the work that Survivors Against TB does, it's very, very survivor-centered, focused survivors. In fact, from something as minute as if there's a statement, SATB does not sign a letter. Survivors will individually sign. Unless all survivors agree, then we'd maybe sign as SATB. But even something as minute as that, right? There's a lot of autonomy and agency and just recognizing that you're working with these people as equals and not as a means to an end for your service delivery or your token representation. So, yeah.
Okay. Great, thank you so much for this amazing answer. So we'll move to the next speaker, and if there's more questions, use the chat, and hopefully we'll have some time after. Faith, could you start sharing your screen? So our next speaker is Faye Mugodi. She's a social scientist from Milton Park Clinical Research Site in Zimbabwe, and has been involved in several TB and HIV prevention and treatment clinical trials, and sort of strives to bring patient-centered approaches into these research situations. So Faith, the floor is all yours.
All right, thank you so much. So I'll just get right to it. So I'll be focusing on community engagement strategies that we use for an MDR-TB trial we conducted here in Zimbabwe, and how those strategies were used and the lessons we learned from employing those strategies. Okay. So this is just roughly an overview of the status of MDR-TB in Zimbabwe. Zimbabwe has transitioned out of the 30 high burden countries, but still remains in the 30 high multi-drug resistant rifampicin resistant tuberculosis TB burden. And the prevalence of MDR-TB has just remained stable ever since a survey that was done in 1994. So we had an MDR-TB study that we conducted at the site. And this was a prevention study that was targeted at household contacts of MDR-TB patients who are already on treatment. We were set to recruit about 70 and about 140 household contacts. We did the preliminary work, engaged the CAB and community clinics as well before we set off on the study. So we had some challenges in the beginning, such as like competition for potential participants from local organizations. Most of our participants were located far out of the recruitment radius. We had myths and misconceptions, hindering our recruitment efforts, which fed into a lot of stigma related to our study. So we had to think of ways to recruit index cases and provide prophylaxis to their household contacts. So we thought of adjustment of recruitment plans, providing further training, collaborating with other organizations as opposed to competing for participants or patients, and incentivizing or strengthening our community relations. So in terms of adjustment of recruitment plans, we had to make applications to local IRBs to extend and widen recruitment radius. Our recruitment radius was 40 kilometers from our site, and we ended up having that extended to more than 100 kilometers. And this accounted for more than half of our enrolled participants in the end. And so we saw a significant improvement in that. So we end up also targeting mining towns in our screening process and encouraging testing and discussing potential benefits with clinic staff in these towns as well. And also following up of lab results for potential participants, as most of the lab personnel tended to issue these results way later. They didn't see any need for emergency or whatsoever. So we had to also have discussions with them and see how we could improve at the results dissemination. And this also fits into the training and education. We ended up also having to work with village heads, community clinic staff, village health workers in our efforts to improve recruitment strategies for the index cases. So here is an expansion of the collaboration that we did. We end up working with the Ministry of Health and Childcare, approached the provincial medical directors, also working with the National AIDS Council and also the TB Survivors Association of Zimbabwe to host this was last year. We worked together with them to host the belated TB World TB Day. And this is where our CAB had an opportunity to highlight the importance of TB and MDR prevention. Community health workers were also included in these efforts. So we're also looking at incentivizing and strengthening of community relations. So this in itself, even though we had these workshops that we're also having, we also worked closely with these council clinic staff who would also have access to TB results. And so we created a WhatsApp group with council clinic staff, provincial TB coordinators, medical officers, lab teams within the recruitment radius. We provided airtime for phone calls to the study clinic and which also enabled them to report MDR cases early to the clinic. So there are various disciplines, just a rough mention of people who took part in this community endeavor. We had the nurses, both the community and our study clinic, counselors as well, doctors, community health workers, the village health workers, pharmacists, CAB. It was an all hands on deck type of effort. So what did we learn from this? Like my previous speaker was saying, engaging the community and in TB research is crucial. We also found that engaging influential people in the communities can play a critical role in promoting awareness and acceptance of TB preventive treatment initiatives. So we also found that widening our recruitment area increased chances of finding potential MDR patients. And also words matter in the communities in an effort to reduce stigma associated with TB. So this proved to be very important, how you address people, how we talk to people, the words we use. This all is important in how they see the studies that we do or any preventative efforts that you may have. So it is just an addition that it's common practice within the Zimbabwean culture for TB patients to be shrouded in superstitious beliefs. And so all of these, we needed to also help to allay these fears, that these traditions that they had, and to help people understand the need for preventative measures for MDR TB or just TB. So yeah, this is my presentation. I hope we could all unite to bring an end to TB through our efforts within the communities. Thank you.
Thank you, Faith. So I'm going to ask to hold on to the questions and type them in the chat, and then Faith can answer them while we hear from the next speaker, and that way we maybe have more time at the end. Thank you so much. Okay, so then we'll move on to our next speaker, who's Stephen Molldrem. He will talk about supporting TB sequencing in Botswana using empirical bioethics, science and technology studies, and implementation science. Stephen is a qualitative social researcher, health policy analyst, and ethnographer, and assistant professor at the University of Texas Medical Branch in the Department of Institute for Bioethics and Health Humanities within the School of Public and Population Health. Wow, that is a long affiliation. Stephen, the floor is all yours.
Great. Hi, everyone, and thank you very much, Nora. I appreciate it. So yeah, today, thank you so much for SHIFTB for hosting this TB Day event. So I'm going to be talking about some of the research that we've done in Botswana using a variety of approaches and interdisciplinary collaboration, using methods from empirical bioethics, science and technology studies, and implementation science to support the implementation of genomic sequencing for TB diagnosis and other uses in Botswana. And so I want to just say a quick thanks to all of the collaborators who are involved in this work, who are there on the screen, and there are even more. It's a large undertaking. I have no financial disclosures to make, but I would like to thank our funders, the U.S. National Institutes of Health through a bioethics supplement, and also my institution, which has very generously supported this work through several pilot funding opportunities. So some background. So since 2022, we've been using approaches from empirical bioethics, this field called science and technology studies, which I might have some time to talk a little bit about what that is, and implementation science to support the implementation of genomic sequencing and targeted next generation sequencing for tuberculosis in Botswana. I'll talk about sequencing. There are different varieties. I'll generally just refer to it as TB sequencing. And so we've examined perceptions of ethical issues about TB sequencing technologies among key stakeholders in the country. And now we're also assisting in the development of evidence-informed implementation strategies for TB sequencing. So our work has helped lay the groundwork for implementing a technology called targeted next-generation sequencing for TB in Botswana. As some of you might know, targeted next-generation sequencing, or TNGS, was recommended by the World Health Organization in 2023 to implement in all countries with capacity to diagnose drug-resistant TB. So there's a summary of our two studies. The first is the Bioethics supplement study, where we engage stakeholders to assess whether they would want sequencing, which I will describe in a moment. And the second is the study we're doing right now, which is ongoing, which is using methods from implementation science and STS to generate, by talking to stakeholders, including people in the health system and people living with and affected by and who have survived TB, to develop implementation strategies for this novel technology. For some additional background, as we all probably know, drug-resistant tuberculosis is a huge problem, kills over 200,000 people per year. Most cases of drug-resistant TB can be detected. However, the dominant methods used to diagnose drug-resistant TB take a long time. The gold standard methods, phenotypic drug sensitivity testing, and point-of-care tests, such as GeneXpert and TrueNat, are limited in the range of resistances that they can detect. So frequently cases of DRTB go undetected. And so the promise of sequencing for drug-resistant TB is that it can detect a wider range of other types of drug resistance than other molecular diagnostics, like I said, such as GeneXpert or TrueNat. It was recommended to be implemented in 2023 by WHO in all countries with capacity. There are drawbacks to it, such as it is not a point-of-care diagnostic. It has to be done in a centralized lab. It's rather expensive, requires sequencing equipment, training, a steady flow of reagents. And so implementing it is a very complex undertaking. And there are currently no generalizable implementation strategies for implementing targeted next-generation sequencing, despite the WHO guidelines. So we're working with the Botswana Ministry of Health right now to conduct a pilot study to develop some of these strategies. But actually, before that guidance came out, we were already interested in what stakeholders in Botswana thought about TB sequencing, because the partnership that I'm part of, they do genomic epidemiology studies using whole genome sequencing of tuberculosis. So before this guidance came out in 2023, we had actually put together this study to talk with using frameworks from science and technology studies, anticipatory governance, and empirical bioethics, to understand what stakeholders in Botswana thought about the use of sequencing for TB to detect drug resistance and for other uses. And so actually, while we were analyzing our results from this study, which was when WHO released their guidelines recommending the implementation of sequencing. So it was quite a timely study. And we conducted interviews and deliberative dialogues with stakeholders in Botswana, like I said, including policy stakeholders, research stakeholders, and community members. And to spur ethical discussions, we created this video series, which if you look up our publication in PLOS Global Public Health, you can actually watch. We made a video series in English and Setswana for folks to actually explore ethical issues related to the technology by telling the story of a family that experienced TB diagnosis and contact tracing informed by sequencing. I'm not going to get into the details of the findings. However, we found broad and universal support for sequencing in the country, so long as stakeholders were engaged and educated throughout the process. It was properly resourced by the Ministry of Health and maintained, and that basically people were kept up to date as it was implemented. People really, really wanted this. It was like, how can we have this yesterday, was kind of the tone of the respondents. Even though it was complex and costly and all of this. And so then we moved, after we did that study, into the implementation science study that we're currently doing, where right now we're finishing up our interviews with TB stakeholders and starting to analyze that data, where we will identify gaps in the cascade that could be filled potentially to get samples to labs faster and to capacitate labs to implement targeted next generation sequencing. And so we're doing those interviews now and analyzing that data. Then we will take those strategies and we will workshop them in focus groups with stakeholders to select the preferred implementation strategies. And then from there, we will actually prepare materials and like a report and deliver it to the Ministry of Health so that they have strategies available to them should they choose to implement the technology according to the WHO guidelines. And so in conclusion, we've used a variety of approaches to show that TB sequencing can be ethically implemented in Botswana by engaging a wide variety of stakeholders. And in this innovative and interdisciplinary partnership, we're now developing implementation strategies for TB sequencing in the country, which in a pretty cool way are hopefully at least somewhat generalizable to other contexts to support that 2023 WHO guidance for implementation in other settings. So thank you very much. And that is the end of my presentation. Thanks again, Nora and SHIFTB.
Thank you, Stephen. That was perfectly 7 minutes exact. I suggest that we move to the next speaker and ask questions in the chat. Stephen, if you could just monitor also a little bit of what's coming up. So our next speaker is Jonathan. Jonathan, would you like to share your screens as well? Yeah? Okay.
Yep.
Jonathan Stillo will talk about moving beyond directly observed therapy. He's a medical anthropologist and an assistant professor who teaches anthropology and public health at Wayne State University in Detroit. He's also the elected co-chair of the TB Europe Coalition and a member of the Global TB Community Advisory Board, and has also taken up different sort of expert roles around WHO work, among others, the World Health Organization's European Office Working Group on Patient-Centered TB Care. Jonathan, the floor is yours.
Thank you so much for having me. I'm really excited to talk about this. So I've been, so these are some of my affiliations, but I'm speaking in my personal capacity. And I would say that my work on DOT sort of began at the demand of the people who were being treated. I didn't begin this work specifically on the issue, but it became really clear that DOT was something that was causing challenges for people who were being treated. And I think it's a really important thing for social scientists to work on, in that it's this really complicated situation where you have a lot of different stakeholders and some people with very strong opinions about how it ought to be. So some of the folks that I've worked with are TB survivors and other affected community members, civil society, clinicians, and also policymakers. And I think you really have to have all of these folks involved to think about DOT. So, but most importantly, I want to underline, really, we should be privileging the values and preferences of people with lived experience of TB. So one of the things that I very quickly realized working on DOT is that this is something that a lot of people don't really tolerate questioning. It's just something that is done in the TB world. It has been done this way, and there's very much a one-size-fits-all approach to it in a lot of places. And I would say particularly in my country, the United States, which sort of exports this particular thinking about DOT. So, but we know that DOT is not happening as described on paper in a lot of places. And I did some initial work on this in Romania, but other work has been done in India, in China, in Brazil. Basically everywhere you look at how DOT is being practiced, there's a great variety. And sometimes this is because of a lack of reach of public health systems. This was the case in Romania, where DOT was just impossible to provide in rural places. But they said that they were doing it because they felt that they needed to. And in the end, what this did was created a real burden on patients and their families who were having to travel long distances, collecting bags of medicine, which they would bring back home. So one of the things that I've been doing is a human rights analysis of DOT. And I have these two, I want to highlight these two papers, one of which is one that I wrote, and on the bottom is a very, very good one that came out recently by Brian Citro and others, who do a really in-depth analysis of the practice. And one of the things that we find is that DOT is not in keeping with human rights. There are a lot of problems with it, particularly around the burden that it places on people with TB and their families, as well as questions of the ethics of it, given that the research just does not support that it improves clinical outcomes. If you actually look at the data, it really doesn't support the practice. And even WHO says that it's ethically justifiable only when it's done as part of a patient-centered approach to care. And oftentimes we see that that's not the case. So I quickly wanted to highlight a couple areas where there are some challenges with it related to the right to health. And one in particular would be accessibility. As I mentioned earlier, people have a hard time taking part in it, particularly if they are working or have children or elders that they're caring for. It can really, specifically facilities-based DOT, can really interfere with people's lives outside of being a person with TB, because their lives don't stop just because they have this disease. Another aspect that I think is really important is this question of acceptability. Is the way that DOT offered in a place acceptable to the people who are being treated? Is it offered in places which are convenient to them? Is it provided by people who they would like it to be provided for? And oftentimes that's not the case. And then finally, this question of quality. And can we really say that DOT is a quality health intervention when there's such a weak evidence base justifying its use? So just a little bit of ethnography. I've interviewed a lot of people about their experiences during treatment, and one of the things that we found first is that there's a lot of diversity, but also that there are real challenges with participating in the community. People are unable to work. People lose their jobs because of the stigma related to TB, and DOT is actually one way that people are outed for having TB, because they see treatment, they see them going to treatment sites, or they see workers coming to their houses. So there are real privacy concerns, as well as these challenges of accessibility. And we'll quickly go through this. What people told me that they needed was that they needed support, and not just transportation reimbursement, but like really thinking holistically about what does it require to be treated for TB. So lost wages. They needed support for childcare, so that there was someone to watch their children or elders while they were being treated. They needed support to keep their homes heated. So all of these, really social and economic challenges. They needed peer support. TB can be a very isolating experience. They needed psychological support. And most importantly, people wanted flexible options. And this is not, so some people preferred things like VOT and digital assisted treatment, but others didn't want that kind of surveillance. People wanted the ability to travel. So there's really a diversity of things that people with TB have asked for. And I think this goes completely against the idea that one size fits all in terms of the way that we have traditionally approached DOT. So to be a bit provocative, one of the things that I would ask is, if we were inventing this today, if you brought together the smartest people in the TB community, would DOT be the thing that we came up with? And I'm convinced that it absolutely would not be. This intervention would be rejected today by people. It's just something that we've sort of dragged from history with us. And I think we could do a lot better. And what the future might look like, and I think should, and I hope future work is going to work around this, would be rights-based, person-centered approaches developed with TB survivors, at the center, and really thinking about individually differentiated care. Different people need different kinds of support, and we have to create a system that allows that to happen. And I think, this is really the perfect time to start having these conversations and thinking about a better way that we could do this. So finally, I'll put in a little plug. My article on DOT is actually going to be discussed by the SHIFTB Journal Club next month. So this is the invitation for that. And thank you so much for having me. I'll stop sharing.
Thank you, Jonathan, and thank you for also advertising the Journal Club. That's wonderful. Helene-Mari, we're moving on to our next speaker. Would you like to start sharing your slides? So Helene-Mari will talk to us about using knowledge for action, TB proof as a powerful collaboration. Helene-Mari Van Der Westhuizen is a postdoctoral researcher and lecturer at global health at Oxford University. She's a trained medical doctor, but then I think embraced qualitative methods during her PhD to examine TB prevention in rural and low-resource contexts. She's also the co-founder and vice chair of the board of the TB advocacy organization TB Proof. Helene-Mari, the floor is yours.
Thank you, Nora, and so lovely to be here with you today. I want to offer some thoughts on the power of collaborations between non-governmental organizations and researchers, and I'll be drawing on some experiences of TB Proof over the years. And I think an important point to start off with is just acknowledging the power of social science research. And I think Jonathan's presentation was such a great example, where I don't think the researcher has to remain this impartial observer, a distant observer of science, but instead can be part of creating the knowledge, creating new understandings, and their unique position to the research topic does influence the output in a positive way. So I want to start with this prompt. How can we use research, not just for observing or understanding, but how can we use research for action? Because when we're working in a field like TB, there is so much that needs to change and to improve the prevention and care for millions of people. So I'd like to draw on the experiences of working with TB Proof and offer 3 examples of how I think the collaborations between researchers and advocacy organizations can help to produce knowledge for action. And so the first point is, I think these collaborations can help focus attention on overlooked topics. And so DOTS being a great example. My own learning on this was also through TB Proof. So back in 2012, when I was still a medical student, we realized that our classmates were falling ill with TB due to being exposed in the hospitals where they were training. And as part of a small undergraduate research study, we developed a training intervention where we tried to persuade our fellow classmates that they were at risk of TB, but that there were things that they could do to prevent themselves from falling ill. And we also documented the impact of TB on medical students and their overall well-being. And I think importantly, we learned how to then use this research for local action. So we took these papers to institutional guideline meetings, say we need further guidelines to protect students. So that was my small introduction to this. I think a recent focus that TB Proof has been pursuing is specifically, sorry, I'm just trying to close my pop-ups. I hope you can still see my screen, there we go, is co-developing TB stigma intervention, because TB stigma is often flagged as a really important consideration, but really what to do about it, we feel is an area that needs more focus. So this is a research advocacy collaboration that the phenomenal Ruvandi Natavitarana is leading, and the specific focus is how that point of receiving your TB diagnosis can also be an opportunity to receive counseling, and how that might mitigate some of the stigma that people experience. So if you're interested in hearing more about this, please get in touch. But I think the prompt for this is just to ask, what are the topics for you in the field of TB that you think are currently being overlooked? And could this be a starting point to create knowledge for action? So my second example of advocacy research collaborations is how it can help take some of the research ideas into policy spaces. So again, a TB Proof example, we looked at how TB policy implementation works within the South African policy context, and how a policy is often formulated on national level and then makes its way through to the provinces. And then, you know, there are a few blockages in the system, but sometimes it ends up more at a local level. We published this as an academic paper, but actually through TB Proof had the opportunity to share this with some role players within the South African National TB Program. And we've learned that creating short policy briefs that summarizes a research article or a longer policy document can be incredibly effective. These policy briefs can be used by policymakers, but we've also had experience in sharing these with community leaders that can then use them to prompt policymakers for action. So my question here is, what research do you feel should reach a policy audience? And how can this research be packaged in an accessible way? Moving to the third example, and that is how these advocacy research collaborations can help challenge researchers to think more creatively about the routes for knowledge dissemination. So I think through TB Proof, we've learned that the peer-reviewed publication is definitely not enough. We need to look at opinion pieces, social media, radio interviews, and we've learned a lot from our collaborators. And I want to specifically mention the South African Health Journalism Centre, Becky Sisa, who offer training for researchers on how to communicate with a public and with a policymaker audience that we've hugely benefited from. So the prompt here is to think, what sources are important to reach the people that need to hear about your research? Slide, I want to shift gear and reflect a little bit of what we had to put in place within TB Proof as NGO that are enablers for helping TB Proof engage in research as a research partner. And first of all, it's hugely beneficial to engage TB survivors at all of the facets of the research process. And as Ashna referred to in her talk, TB Proof has often used peer research associates to support some of the data collection. But we found that it's incredibly important that when it comes to data collection, to also have the resources available to provide a supportive environment, because engaging with people who are in the midst of a challenging experience as part of their TB journey could often resonate or take a toll on the interviewer. So it's important to recognize that and account for that. And secondly, for certain kinds of research, especially around TB stigma, having organizational visibility in community contexts over a longer period of time have enabled us to create longer term relationships beyond the shorter project cycles, and that's been incredibly valuable. And thirdly, we've found that participatory research methods have had quite a broad application across different projects. For example, tools like a card deck with different pictures that show different stages of the TB diagnosis and treatment journey have been a really valuable tool to engage a wide range of people in helping to design what potential interventions could look like. And we're quite excited about expanding the use of participatory research methods to center the experiences of people affected by TB in future research work. So in conclusion, on a personal note, for me, working closely with TB Proof while also being an academic has been an incredible experience and helped, I think, keep my research grounded in what the realities are of having TB. And my TB Proof colleagues are incredible, and they deserve so much recognition for also taking on the challenge of engaging with research as part of their work. My hope for the future, and I want to acknowledge that our broader TB community is facing some formidable challenges, is that we use empathy to root our research into the experience and expertise of people affected by TB. Thank you.
Thank you, Helene-Mari. This was wonderful and lots of food for thoughts for us social scientists, how to get involved and move knowledge to action. I'd like to open the floor now for general discussion and comments and questions you might have. And as you think of this, I thought what really spoke to what brought these talks really nicely together is that when thinking through, well, what is the key role for social scientists and what's the added value that we can bring to this discussion? Well, clearly all of you have shown that one size does not fit it all, right? We need to diversify our strategies in the way we engage with TB survivors. We need a diverse set of implementation strategies for novel interventions. We need to think about diverse ways in engaging communities in research. There's an argument made for differentiated care models by Jonathan and diverse channels that we use for, bringing our knowledge or translating it to policy. And I wonder if we as social scientists can really sort of take this on to diversify these options and research these different ways and show methods in which you can, like strategies for generating solutions that aren't universal, right? But I'm curious what all of you are thinking and hearing, so please use the chat or raise your hand or just shout. We're not such a big group.
Like to ask Jonathan a question. So Jonathan, I think also just on personally, but also on behalf of TB Proof, we are so on board with your advocacy that you're doing around dots and sort of broadening the number of options that are available to people affected by TB. How can we make sure we generate enough momentum to make sure this message reaches a wider audience, because it feels like there's so much momentum behind dots as a principle, and I feel the WHO has made subtle shifts in the language that they use in the documents, but I think sort of a statement that might be a particularly valuable tool. What are other opportunities that you see that we could help shift momentum from dots?
Yeah, it's a really good question. I think in the about 20 years I've been doing this, I've seen a real shift where actually the first time I ever presented on DOT, it was thankfully a video recording that I gave for the NSF Science Day in Ukraine. And when I asked how it went, folks said, you know, some people have really strong feelings about it. I think there's a lot more momentum, and people are willing to think about this more critically now. And I'm hoping that we can, we just had a plenary on DOT at the North American Region Union Conference, and it went, and Amrita was on it with me as well. And I think it went really well, and people were generally supportive. So there is a momentum, I think, within the community, but also a willingness for more people to accept that, you know, actually maybe this one-size-fits-all approach is not working for people with TB. So we just have to keep pushing. We have to keep publishing. We have to keep, you know, moving this forward, and hopefully we can do something in the US and Canada to start changing guidelines. I think the United States guidelines in particular are well behind the world, and I hope South Africa will also be helping to lead the charge, because, you know, South Africa has really been a leader in terms of changing the way that we think about a lot of things. But I'm happy to work with anyone who's working on this issue. I think it's something we really have to change.
Thank you, Stephen. There's a question for Helene-Mari in the chat that hasn't been answered yet. Helene-Mari, could you please give some examples of maintaining longer-term relationships beyond shorter project period, I guess, with the communities?
Yeah, I think what we found is often a project would be in a year or 2 years, and that if you want to have discussions about topics that might be emotionally charged or sensitive, like, you know, gender and TB or stigma and those kinds of experiences, I think it's important for the organization to be known in the community and to know what kind of work is done, and for the sort of the face of the organizations, the people doing the data collection, to also be known. So I think our strategy from TB Proof's perspective has been to choose a specific district and say that we are trying to focus many projects in this area, and then build relationship with key stakeholders over a period of time, because we found that if we make a shift, it takes quite a bit of time to initially build those relationships. So I think it's more been a pragmatic organizational decision to try to go for depth instead of, you know, trying to spread ourselves really thin and have projects in many different areas of South Africa. And I think I also just want to give a shout out to Goodman Makanda, who and Pumeza Tasile, who does incredible work in maintaining those relationships in the community context, specifically in Khayelitsha and Cape Town.
Thanks, Helene-Mari. Are there more questions or comments or thoughts?
Hi, Nora. Can I just step in?
Yes, please, Chair Meyer, go ahead.
Yes, thank you so much, Nora, and thanks to all the panelists. Really, yeah, you gave very interesting texts and angles to this important issue. I was just thinking about in Southern Africa, where Stephen, you've been working, and Faith, and Faith did mention the issue of culture as one of the challenges. And I think from other work, we have also seen some kind of challenges in terms of managing the issues of culture, especially when it comes to invasive procedures or procedures that have to do with anything to do with the body. So, Stephen, I think you seemed to have overcome that, but did you kind of see that coming into play at any point?
Yeah, so thank you so much for this question. You know, part of what I didn't get to kind of talk about in my very short talk today is this very specific context of Botswana, where there's a great deal of trust in the healthcare system, and the healthcare system is actually quite strong, and there's a lot of support for things like adherence, also, you know, high quality lab facilities and transport of samples. And so this idea that the state is going to implement this new technology that is a new kind of surveillance technology that is going to have a diagnostic benefit, but also potentially enable new forms of surveillance that can support adherence, but are also using folks' data in new ways. You know, we were not necessarily expecting that people were going to respond positively to this at all. However, there's this long history of a very strong and somewhat paternalistic but supportive state, right, and social safety net in Botswana that led to people really wanting this, including the TB survivors who we engaged. And part of what I was saying to Nora in the chat is, I think this is why it's really important to engage social science and kind of any implementation of something new like this, because you could go into a different country and find a completely different story instead of reactions and thoughts about this. So I think the particularity of our context is part of why is a big part of the story in terms of the success that we've had in thinking about these interventions.
Thank you, Stephen. Thanks, Nora.
Any more questions, comments? Ideas what SHIFTB could do? more of. Okay, then we're right on time with a comfortable round of discussing a few points and a really nice set of questions in the chat and a wonderful combination of talks. It was really nice, I think. Very different approaches to doing transdisciplinary collaborations, and everywhere a good and important role for social scientists to play. So I'm really excited to see that, and lots of food for thought for all of us, including, I think, SHIFTB has to write some policy briefs or get better at that, because those are always, you know, once the publication is done, we're all so tired. And now we have to write a policy brief, but okay, maybe AI can help us with that. Okay, wonderful to see all of you here. Please turn on your cameras quickly so we can take a picture. Now somebody has to take a picture. Oh, I have to do my phone.
Nora, I can take a screenshot for us as well.
Okay.
Okay.
Really nice to see so many of you here. Please sign up to our newsletter. Reach out to us if you know or hear of interesting projects in the social science and TB space. We're always interested in learning what's going on and bringing people together. If you have ideas for newsletter items, please reach out to us. And yeah, really excited to see so many of you joining in.